So I am going to go through how to read an MRI. So first what I do is I will not look at the history, and I mean you can look at the history if you want to. It's up to you. This is just the way I do it. The main thing is to go in order and stick with that order and just do the same thing all the time so that you don't miss something. Anyway, and different institutions do different things, but I will just go through what University of Illinois in Chicago does, just because that's just what I'm used to. So I don't look at the history. I look at all the images first, so I try not to bias myself into what I'm seeing. I will look at the scouts to make sure that there's nothing else on there that might be outside of the breast that I'm not paying attention to. So this case is from Radiopedia. It's dense breasts in normal case. So I just chose it to kind of show you guys what's what. So I will look at the scouts first, and then I will look at the T1 non-fat sat. This is just the order it comes over to me. So whatever order it comes over to you, it's probably a good order to look at it in. But the order that it comes to me is the T1 non-fat sat, and you know that's non-fat sat because the fat here is bright. Then I will, I'll just scroll a little bit. Okay, and then I will look at the T2 fat sat just to kind of look what's going on. If there are cysts, I do not name every cyst. This one doesn't seem to have cysts, but I can't window it. I would like to, but I can't. Anyway, I would I don't measure every cyst, because some patients have breasts chock full of cysts. So usually with the cysts, if they're really small and all over the place, I'll just say bilateral sub-centimeter cysts in both breasts, bilateral benign sub-centimeter cysts in both breasts. If she has some big cysts, I might say bilateral cysts, the largest on the right in the upper outer quadrant, measuring 4.9 centimeters, and then I put the series and image number. I try to keep my reports pretty simple, just because you don't want to confuse the referring provider with a lot of words, especially if something's benign. I mean, there's no point in just talking all about all this benign stuff. Though there is a point, but for example, if there's a cyst that needs to be aspirated. But anyway, I just try to keep my reports pretty simple and direct. So after I see the T2, look at the T2, I will go to the post-contrast. Now with the post-contrast fat sat, remember, actually there's another one that I look at, the one before this, which I don't have an image of. I will also look at the T1 T1 fat sat, non-contrast, because you need to look at that. Reason why you have to look at that is because you want to make sure when you see enhancement on post-contrast that it actually wasn't already bright beforehand on the pre-contrast. So anyway, this is not a pre-contrast because I see contrast in the internal mammary vessels. Sometimes it's hard to tell by just looking at the heart if it's post-contrast or not, but so I look at the internal mammary vessels to see if it's post-contrast, and this one's post-contrast, and you'll have three post-contrast, at least three post-contrast images, but I probably wouldn't have more, just because you should be able to really see everything you need to see on the three post-contrast. And when going through them, I usually will just go in order. I'll go look at the right breast, go all the way through. I will go to the left breast all the way through. And remember, the nipples enhance. So when you see enhancement in the nipples, that is normal, but you want to look for asymmetry in terms of nipple enhancement. And it's not going to be necessarily all on the same image where the nipples are, because not everyone is symmetrical. Actually, most people are not symmetrical. So, in terms of where their nipples are. Now, this patient is actually pretty symmetrical, but what you're looking for in terms of nipple enhancement is asymmetric nipple enhancement. So you first look at the breast, right breast, left breast, nipple asymmetry. I look at, and then look at the internal mammary. I look at just kind of follow it up to down, and to make on the right, and then I do it on the left to make sure there are no internal mammary lymph nodes that are enlarged, especially in someone who is getting cancer staging. This particular patient was getting high risk screening, was 30 years old. So after I look at the internal mammary, so I always go right to left. Right lymph nodes, axillary lymph nodes, and there is quite a large variety in terms of right and left. I mean, in terms of normal lymph nodes. So sometimes you have to look at the right and you might say, oh my gosh, it looks enlarged. But then you look at the left and it looks pretty much the same. So I'm not talking about super enlarged, like obviously metastatic. I'm talking about like a little bit. Sometimes it's hard to tell if it's abnormal or not. But so I go right axillary, left axillary. Then what I do is I kind of go back here to the non-breast stuff and look through from, say, superior to inferior, down on one side, and then up the other side to make sure I'm not seeing anything. And it's really good to just read even a lot of normals. So somehow your brain is kind of like taking in normal. So some people, they complain like, oh my gosh, I had to read all these normals. It's so boring. There's no pathology. Once you get your eyes on a lot of normals, abnormal will just pop out at you, and kind of it'll attract your attention, and your eyes will be attracted to it. Okay, so and then after that, I look at the sagittal. We do sagittal post-contrast fat sat. So anyway, I'm not showing the whole field of view, but I go from one side to the other. So I look at the breast, I look at the internal mammaries, I look at the axilla, and then I look kind of posteriorly at everything else. If you have, especially someone with cancer staging, and this one is just high risk, this is the internal mammary area. If you have someone who is high risk, you're going to be kind of reading that a little differently than someone who is cancer staging. High risk, you're looking for anything, you have a higher threshold for calling back, which means something's got to be abnormal on there for you to call the patient back. If it is for cancer staging, I think I have a lower threshold of calling somebody back because it's for cancer staging. And some of the things that you have to put in your report are, of course, size. And I always look at the mammogram and ultrasound, when the patient got diagnosed, to make sure that everything that I see matches up. Like it makes sense, the size on MRI is the size you see in ultrasound, and you want to report especially things that would make a difference in their management. For example, if you want to see, is there nipple involvement, is there skin involvement, is there pectoralis muscle involvement, is there how many lymph nodes you think that are involved. So those are the things that you want to put in your report, because you just don't want people having to try and reach you to figure out this stuff, especially because those kind of things make a difference in management. For example, if the nipple is involved, they may have to take the nipple off during the mastectomy. If the pectoralis muscle is involved, they may have to do radiation there. If a larger area is involved on MRI, or you think there might be because of non-mass enhancement, you got to say that. Now, if you see some enhancement that you think is abnormal, some people, if it's under like 6 or 8 millimeters, they will recommend an MR guided biopsy and not do the second look ultrasound, because the likelihood that you're going to actually see something and have the thing that you see be the thing you saw and have the thing on ultrasound be the thing that you saw on MRI, you know, we don't really know. So sometimes when it's very small, we just recommend an MR guided biopsy instead of doing the ultrasound guided biopsy, or doing the second look ultrasound and possibly the ultrasound guided biopsy. You also want to look at the MIPs. Some people look at those first. Sometimes I look at them first also, just to get an idea of like overall, okay, what am I looking at? Just to get overall, like, oh, is its enhancement symmetric? Oh, there's something on the right side or the left side. But it kind of gives an overall assessment of what's going on in the breasts. You also want to look at Dynacad or whatever app you use to look at the kinetics, and you want to look at that also. Okay, well, that is the quick and dirty of how to read an MRI.